Okay, so we are going to finish out our section on renal and urinary system disorders with this last part of chapter 46, CKD, where a lot of our focus with AKI in this PowerPoint was on the different etiologies and the categorizations of those, whether it's pre, intra, or post-renal. And then the 3 phases of clinical manifestations, that was oliguric, diuretic, and recovery. For CKD, we're going to focus largely on the clinical manifestations as they present in other body systems. So when the kidneys fail, every single body system is affected, and we're going to break that down by system and go over it. So as you're studying for this portion, that will be where most of your studying lies. It is a progressive, irreversible loss of kidney function, chronic kidney diseases. The leading causes are diabetes and high blood pressure. It is more common than AKI, as we mentioned earlier, and it is like criteria to be diagnosed with CKD is a decreased GFR less than 60 for 3 months. Not just a second. My cat was knocking on the dang door. Anyways, the criteria to diagnose CKD is a decreased GFR less than 60 for 3 months. So this is a fairly common condition. 70% of people don't even know that they have CKD. 37 million American adults have CKD, and millions of others are at an increased risk for it. Heart disease is the major cause of death for people who have CKD. Glomerular filtration rate is the best estimate of kidney function, and that's true not only in CKD, but kind of across the board in terms of assessing kidney function. Of course, we have GFR, which should be 80 to 125. We have creatinine, which should be 0.6 to 1.2. And then we have BUN, which should be 8 to 20. When creatinine and BUN are elevated, kidney function is impaired. When GFR is decreased, kidney function is impaired. Don't get those confused. They kind of have an inverse relationship. And then African Americans, Hispanics, Pacific Islanders, and American Indians, and then elderly populations are at increased risk of development for CKD. So like I said, we're going to break this down kind of by body system. Chronic kidney disease will affect every single body system. One kind of thing that can happen across the board is uremia, which is urine in the blood, just as it sounds with its prefix and suffix, from retained waste products. Often this occurs once the GFR hits a level of 15 or lower. So that's a pretty significant loss of kidney function before we'll see this occur. Now, this picture here is a good, I really like it because it's a good summary of everything we're about to talk about in a little bit more detail in these future slides. So kind of come back to this as you're studying to piece it all together. So of course, in the urinary system, we'll have variable presentations. It could be polyuria if the patient develops CKD from diabetes. It can initially present as polyuria, and then with progression of the disease, we're going to see less and less urine output because the kidneys are functioning less and less. And so oliguria will develop, fluid retention will develop, and anuria will kind of develop after the patient's been on dialysis for a little bit, so no urine production. In the hematologic system, anemia will occur because the kidneys, as we said, produced erythropoietin. Erythropoietin is required for red blood cell production, and so if we are not producing erythropoietin, then we need to address that. And that is a medication we'll actually give our patients who are on dialysis and in CKD, but they are usually chronically anemic. They may require iron supplementation because of their anemia. And then they'll also have altered platelet and white blood cell function, so they are at an increased bleeding risk and an increased infection risk. So they are, well, for example, with COVID, I was going to say they're high risk for infection, and we've even seen that in news recently, or within the last year with COVID. Patients who have CKD or who are on dialysis have been a population that have been hit the hardest with COVID because of their immunocompromised systems. Metabolic disturbances, because of the waste product accumulation, we'll see metabolic acidosis. Altered carbohydrate metabolism will occur in CKD. and that will lead to hyperglycemia, and hyperinsulinemia. So high levels of glucose and high levels of insulin within the body, and also elevated triglycerides. With those elevations in glucose and triglycerides especially, that can just further worsen any pre-existing cardiac diseases or lead to cardiovascular disease. In the cardiovascular system, we see that problems within the cardiovascular system do lead to the number one cause of death in CKD. We'll definitely see high blood pressure with this, elevated triglycerides, as we just said. Vascular calcification and arterial stiffness is referring to vessels. So vessels will be kind of stenosed from plaque buildup, also from the prolonged exposure to high glucose counts in the body, high cholesterol and triglycerides in the body. This can all lead to calcification and stiffness of both the venous and arterial vessels. Cardiac dysrhythmias can occur, and the number one reason for that is because of hyperkalemia. And then uremic pericarditis, we talked about pericarditis in the cardiac section. That is inflammation of the pericardial sac surrounding the heart, which allows for the heart to pump without any friction. In pericarditis, we can have inflammation of those sacs, and uremic pericarditis is because the kidneys cause the pericarditis to occur from the urine that has kind of migrated into the blood. The same thing will happen, I'm going to skip here, in the urinary system. We can have something called uremic pleuritis occur, and that's that lining of the lungs. Just like in pericarditis, the lining of the lungs can become inflamed from the kidney failure. In the respiratory system, we'll also see acidosis from the acidosis, the metabolic acidosis that the patient is in from CKD. We'll see the patient try to compensate with Kussmaul breathing. So that's an increased rate and an irregularity to the rate and pattern because we're trying to breathe off CO2. So that's why that will result. We'll see fluid overload and pulmonary edema because the urine or the kidneys aren't functioning properly. They aren't producing enough urine because the kidneys have failed. So we're retaining fluid, and that can lead to issues with fluid overload. Pleural effusions can occur from the fluid overload and the increased risk of infection, and also respiratory infections. In the gastrointestinal system, we can have something called stomatitis occur, which if you've ever taken like medical terminology, you probably know that this is like superficial, painful ulcerations in the mouth from like being super dry and irritated. Patients will kind of report a metallic taste in their mouth. Uremic fever is a urinous odor on the breath. Patients get very embarrassed about that. Anorexia, nausea, and vomiting, weight loss, and malnutrition. A lot of our dialysis patients are malnourished and emaciated, and then they are at risk for GI bleeding. And that's even worse because of their low platelet count and anemia. In the neurologic system, we will have neurological changes expected as a result of increased nitrogenous waste in the blood. We've talked about that already. Electrolyte imbalances, especially sodium. Metabolic acidosis can cause neurologic alterations and abnormalities. And then further progression of CKD will lead to atrophy and demyelination of nerve fibers. So that can definitely be a problem. We need to get them treated to prevent some of these symptoms from occurring. Signs and symptoms are lethargy, decreased ability to concentrate, fatigue, irritability, seizures, and then encephalopathy or coma. They can also experience symptoms with peripheral neuropathy, which is, burning, tingling, numbness in the extremities, and an altered sensation in their extremities, and then even restless leg syndrome can occur. And then the treatment for this, of course, is to get them to dialysis or transplant. The musculoskeletal system will be impacted largely based on calcium and phosphate and electrolyte imbalances, and we'll talk about that in just a second. CKD MBD is chronic kidney disease, mineral and bone disorder is what that stands for. It's in the notes. And that results in complications in the skeletal system, in the vascular system, which we already talked about, in the cardiac system. That calcification and stiffness of the vessels occurs. And then we can see kind of calcification and stiffness of soft tissues as well. This can result in complications such as osteomalacia, osteotitis, fibrosa, vascular calcifications, uremic red eye, which is buildup in the eyes, and then intracardiac calcification, so buildup within the heart, especially at the site of valves. You don't need to know those examples. I'm not going to be like, select all that apply. What are all the CKD, MBD complications? That's way, way, way too detailed and specific. I want you to get the broad picture of what's going on here with these different systems. The integumentary system, we're going to see intense itching, also known as pruritus. That will result in dry skin and sensory neuropathy, but it occurs because of the calcium phosphate deposition in the skin. That'll make sense here in a second again when we talk about the electrolytes. And then uremic frost. I've never actually seen this happen. It is extremely rare, but it's when urine crystallizes on the skin. So it's horrible, I'm sure, to experience and observe. The reproductive system will definitely see kind of like infertility, decreased libido. Dialysis may improve this if we can remove nitrogenous waste and get the kidneys function properly again. The patient is going to feel much more normal and human again, and so that may resolve some of those reproductive issues, and as well as some of the psychological effects, because the patient can experience depression, fatigue, and emotional lability. That's only worsened by feeling yucky and sick all the time from these kidney issues. So if we can get those under control with dialysis or transplant, that would definitely be optimal. So now I'm going to backtrack a little bit. This slide is going to go over clinical manifestations of each of these electrolytes. And I do want to say that I have filled this out. This isn't necessarily something I'm going to spend time on this recording going over, because you can read it right here. But you do need to know what the electrolytes do, whether they're elevated or decreased in CKD, what's the effect of high or low electrolytes, and then how would we treat those. So it's all listed out here. It's not too much information, and it's a lot of baseline information that you already know. Definitely the potassium is going to be high. Sodium can vary depending on kind of what's going on with the patient. Calcium is decreased. Phosphate is elevated. And because calcium is low and phosphate is high, that's what's going to lead to the bone loss of strength and density, and then that predisposition to the CKD, MBD, musculoskeletal system conditions. And then magnesium is going to be elevated as well. When potassium is elevated, magnesium is also usually elevated, so you can remember that. Calcium and phosphate have an inverse relationship, and then sodium can kind of be anywhere. So let me get you back down here. Diagnostic tests for CKD are going to be very similar to AKI. However, if we see protein in the urine, it's usually going to be an indication for some pretty severe kidney disease. If you remember, we'll also see proteinuria with glomerulonephritis. So those are our two common conditions to see protein being deposited in the urine. We'll assess for causes of the CKD with renal scans or CTs, ultrasound and biopsy, and then we'll assess their function. We use GFR to stage the disease. So it's kind of like in the slide that we went over different causes of AKI. This is kind of what that was talking about, like kidney failure, we've got pretty bad kidney disease, and then normal. That's almost an old school way of classifying things. This is before we really got into specifying AKI versus CKD. But yeah, that just kind of gives you a very rough barometer of how we talk about and stage CKD based on GFR. And then of course, your BUN and creatinine will be elevated, and then your electrolytes will be imbalanced based on, that slide that we just talked about. Nursing diagnoses, these are excess of fluid volume related to impaired kidney function, risk for electrolyte imbalance related to our electrolyte imbalances that result from CKD, and then imbalanced nutrition less than body requirements, as we've talked about, the GI system complications, will lead to restricted intake of nutrients. What is our goal for these patients? Early detection and treatment of CKD will save function. So that's what we're trying to do here, is preserve as much kidney function as possible, reduce the risks associated with cardiovascular complications, prevent all system complications, provide for patient comfort, and then educate on effective coping strategies and ensure continuation of ADLs within physiologic limitations. So basically, you're wanting to preserve as much quality of life as possible for these patients. Drug therapy, again, fairly similar to AKI. Treat hyperkalemia, which is on table 46.5, and we discussed in the AKI section. We do want to get the hypertension under control. The goal for most patients is going to be less than 130/80, which is a little higher than normal, but still fairly normal for patients, especially if they have a diagnosis of hypertension. Or we're going to be a little bit tighter on that and say less than 125/775 if proteinuria is present. I don't know who came up with that rule, but those are like the suggested guidelines. And then we're also going to definitely promote lifestyle changes such as exercise, avoidance of alcohol, smoking cessation, weight loss, diet alterations, drug therapy, compliance with drug therapy, the same stuff you've heard throughout this entire section to promote best health. Research on types of antihypertensive medications in patients who have CKD is ongoing. So ARBs and ACE inhibitors are okay, but some studies have found that they can decrease GFR and increase potassium, which we don't want to further do. So you may hear different providers do different things for their patients. For CKD-MBD, which is our mineral bone disorder, we want to limit phosphorus intake because it's going to be elevated, right? Use phosphate binders like calcium acetate and calcium carbonate. So that'll help increase the calcium level within the blood and also decrease the phosphate levels because they have that inverse relationship. And then we want to promote vitamin D intake in their diet because you need vitamin D to absorb calcium. Continued drug therapy, we're going to give erythropoietin at the lowest possible dose because we don't want to send them in the other way and make them hypercoagulable and send them into like a risk for DVT or MI or stroke. But we do want to give them erythropoietin to promote RBC production to a target hemoglobin of 10 to 12 per day. Or I'm sorry, per day. 10 to 12 grams. So of course, normal hemoglobin is 12 to 16 or 12 to 18, depending on what book you read. We want them on that lower end of 10 to 12, which is a very tolerable level for a lot of people. That's a very stable anemia. And then monitor for iron deficiency and give iron if needed. Dyslipidemia, we want to definitely address that because that can progress and worsen cardiovascular disease. So we will give statins. And however, there is some inconclusive data on whether patients should take statins if they're on dialysis. I've seen patients taking statins on dialysis and haven't heard anything about it. So I'm not sure exactly what the outcomes on that will ever be. But if you hear something different once you start practice, that could be why. Nutritional therapy. We will restrict protein. Of course, they're having proteinuria, so we want to restrict that. If they're on dialysis, however, we won't have to restrict that because the dialysis will be filtering it for the patient. The ideal recommendation is 1 to 2 grams per kilogram of the patient's ideal body weight per day. If we can do a fluid restriction, it's not common if the patient's not on dialysis. If they're not on dialysis, we're just going to give them diuretics because they still have some kidney function to be able to excrete the urine. If they're on dialysis, they may need a fluid restriction because we don't want them to be in fluid overload between sessions of dialysis. So most sessions of dialysis go Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. In between those days, we can literally have patients build up fluid to the point of causing complications. So the recommended daily intake is going to be 600 mLs plus the previous day's urine. These patients aren't making a lot of urine, so this is not going to be a lot of PO volume intake. And then weight gain should be less than 3 pounds between dialysis treatments. If it's more than that, they may need different types of dialysis to pull off more fluid or whatever. And then you may see sodium, potassium, or phosphorus restrictions in their diet. I don't need you to know these numbers that are listed here. I just want you to know that they need those restrictions. You don't need to know what the number is per day. Now we're going to talk about the 2 different types of dialysis. All right, so this is kind of the last thing we're going to be talking about. The 2 different types here are hemodialysis and peritoneal dialysis. With hemodialysis, there is a machine that's functioning as the kidney. And again, this is a concept you'll go into way more detail in critical care, but we will just touch on it because this is a lot of times what the end result of chronic kidney disease is going to be for people. So basically, this dialyzer on the hemodialysis machine is functioning as the patient's kidney. They have 2 ports going into their site of their fistula or graft, which is normally in their arm. You may also hear somebody have a Shiley, which is a tunneled catheter in their chest. We talked about it in the nutritional section of our GI system, but that can be used as a temporary dialysis catheter. The goal is to have the fistula or graft in their arm as a permanent method of dialysis. And they basically have an arterial line and a venous line, which takes blood kind of away from their body, takes it through this hemodialysis machine, and this will take fluid off, which is what their kidneys would normally do by peeing, and it filters out nitrogenous waste and electrolytes. So it does both filtering and pulling fluid off. And then once it does all that, it will return the patient's blood back to them through the venous side, and then it'll circulate back into their body. The thing about hemodialysis is they will have to go to a center for hemodialysis treatments on their scheduled days. The benefit of peritoneal dialysis is this can be done at home, and the patient usually has a lot more mobility during this period of time that they're getting their dialysis. So for mobility's sake, this is the preferred method for patients, although hemodialysis would definitely be the most common. And this is basically where a solution bag is hung and the peritoneum is used as the dialysate versus this machine. And fluid is filtered in and then it drains back out into a different bag. Risks of this are going to be like perforation of an organ in the peritoneum. Infection could be a risk because, again, the peritoneal cavity should be sterile. Those are kind of your big things here. And yeah. So if you have any questions about that, let me know. Just a general overview is all you really need. And then on this slide, this is what I really want you to focus on. These are your considerations from a med-surg perspective to be aware of. When a patient has a dialysis, what's it called? Shunt or graft, sorry. It does look like what this picture looks like. It very much protrudes from the patient arm. You usually can't miss it. That arm is going to be a limb alert, no blood pressures and no sticks in that arm. To assess for the patency of this site, you can feel a thrill, you can palpate a thrill. So you can literally put your hand over that site and you will feel like a buzzing vibration. That means it's intact and patent. And if you put your stethoscope over it, you can auscultate a bruit. Excuse me. But again, definitely would not want to take a blood pressure in that arm or put in an IV in this arm because you don't want to mess with the integrity of their graft or fistula or shunt. So there are 2 ways here. The shunt can be, or the fistula can connect an artery with a vein, and that can be where things kind of graft and then get connected to the dialysis machine, or you can see this loop graft where they're connected through a synthetic material. Either way, if I'm just looking at a patient's arm, I wouldn't know the difference. but patients can have either one of those. And then here are our questions here. A 56-year-old woman with type 2 diabetes and chronic kidney disease has a serum potassium of 6.8, which is quite elevated. Which finding will the nurse monitor for? And that's definitely cardiac dysrhythmia. That's your highest risk with a hyperkalemia. Potassium intake can be restricted by eliminating high potassium foods such as, and that's going to be citrus fruits are high in potassium, so we could eliminate those. Your patient had surgery to form an arteriovenous fistula for hemodialysis. Which information is important for providing care for the patient? The patient shouldn't feel pain during initiation of dialysis. That's not necessarily true. The patient feels best immediately after the dialysis treatment. Maybe, maybe not. Using a stethoscope for auscultating the fistula is contraindicated. No, it's actually indicated. You want to auscultate for a bruit. And then taking a blood pressure reading on the affected arm can cause clotting of the fistula. That is the correct answer. You would not want to cause clotting or bust the fistula and cause hemorrhaging, because that's going to be a high pressure vessel. Either one of those outcomes would be very bad for the patient. So the correct answer here is D. Which sign indicates the second phase of acute renal injury? So you have oliguric, it's the first phase where urine output is less than 400 mLs a day. The second phase is diuretic, where they will pee out 4 to 5 liters per day. So that would be A. B would be the first phase, and D would be the third phase, just to kind of orient you to what's going on. C would be like anuria, basically. And that is it. If you guys have any questions about this material, please reach out and let me know. Otherwise, I will see you next Monday for your renal and urinary exam, and then we'll cover one more chapter before the final. It's almost over. You guys are getting so close. So thank you so much. I'll see you later.